Hey there, friends. It's Dr. Russ in Portland. Today I'm going to take you through a neuromuscular and myofascial treatment for the sacrum, the SI joint, and the lower back. I hope you enjoy it and check out all the other cool stuff on my channel. Here we go. Starting without any oil, just kind of getting a sense of the skin and a general feeling for the anatomy, the structure, areas that feel a little more resistant to the touch or a little bit more resistant to movement. Already kind of keying into this left SI right here as being a little bit resistant, and otherwise feeling nice curvatures and good tone, great muscle development, and she feels pretty relaxed. Our patient came in today and said she feels good. She doesn't have any problems. So wonderful. This is a nice proactive session for wellness, and I'm going to demonstrate a basic neuromuscular therapy session going from about S3 to about T9. Let's just see what this looks like. We'll stand at the head of the table and do some really gentle surface level strokes downward. And with these, the intention is number one, to help the patient get used to the feeling, give their nervous system a minute to adjust. Number two, for us to get the skin lubricated and also assess the dryness of the skin, which gives me an idea of how much oil I'm going to want to put on my hands for the different things that I'm going to want to do. That's a little bit of an intuitive process, and it's okay to use a little too much. You can towel it off or spread it around, and it's okay if you don't have enough. You can just get a little bit more. And some people's skin is dry and really soaks up the oil. And so when I come down to the iliac crest and the sacral base, if I use the heel of my hands to give a little bit of inferior traction, number one, that's a nice, gentle little segmental stretch for the lumbar spine. And number two, it gives me a sense of how much compression they're carrying around. And so that's kind of indirectly giving us information about the quadratus lumborum and the deep lumbar erectors and a little bit of the psoas, like if those are hypertonic and the patient's carrying around a lot of extra tension there. Similarly, if the abs are weak or disengaged, person's posterior elements are going to get compressed because they're losing anterior support, and you can kind of get a sense of that as you do this too. So you can see my fingertips here coming under the towel a little bit, and I'm just kind of getting a tiny little saying hello to the piriformis. So this treatment today, we're not going to do much hip work, but it's still nice to get a sense of the piriformis and also getting a sense of what the sacrum is doing, because as my fingers come down here, the sacrum is, like a triangle like this, and I can feel if there's a deviation left, right, or particular. Sometimes you'll feel inflammation or swelling at the lower SI joint, and all of this is just information. So it just feels to the patient like I'm just giving some nice gentle strokes, and that might be what it looks like, but always listening with the hands, asking questions while you work, and also seeing how does this patient's body respond to what I'm doing. Let's move to one side, and we're going to kind of give a similar inferior traction on the sacral base and the iliac crest while the other hand rests on the scapula, just like this. There's a couple of different ways you can do this. Here I'm standing contralaterally, the head of the table, angled a little, sort of at 45 degrees across their body, with the simultaneous stroke outward. The spine of her scapula is here, so the heel of my hand is going along the supraspinatus and the upper trapezius and the rhomboid, while the other hand is tractioning inferiorly. And sometimes even will watch the heel while I do this to see whether the heel is ready to move a little bit while I give this traction down. Let's see what that looks like on the other side. definitely confirming like more resistance here on the left to any inferior or anterior pressure. So that doesn't necessarily mean we're going to press harder. We not necessarily want to force it. Just gathering information. And so I think that we're going to start this treatment on her left side so that I can see if I can figure out a way to improve the mobility of this section here. May I bring this down a little bit? So if you see the top of the gluteal cleft, that's going to be around S4. Of course, that varies from person to person. So the coccyx is going to be inferior to my finger here, and I can feel the sacral apex and coming right here to the lower part of the SI joint. And here is the top of the sacral base. So everything here in between my fingers is the posterior part of the SI joint, from the sacral ala to the PSIS here. And what we're going to do is pick up her foot and use her leg to create a little bit of rotation and inducing a little bit of opening and closing on the posterior side of the SI joint. Now let's use a little bit of counterpressure with our fingers to stretch that fascia and mobilize that SI fascia. So as I pull laterally on her foot, I'm gently creating counterpressure immediately with my fingertips, and my thumb as well is here on the glute and supporting that movement. And so we're creating differential motion between the superficial and deep fascia overlying this SI joint. Now you'll notice I'm not taking time today to assess for malposition or any sacral listing because I'm not going to do any adjusting. We're not going for an articular correction. This is a neuromuscular treatment. Yeah. So now, based on the patient's size and my size, I know that I can lift her leg. There are some patients whose legs I cannot lift, but hers I can. And I can give her leg a jiggle while I palpate this SI joint and feel for play in the joint. And it's moving really nicely. There's a lot of play. I can feel the PSIS and the sacral base kind of sliding in relation to each other. Now let's work that sacral fascia in a slightly different orientation. I'm going to show you with one thumb so you can see. This is not very deep pressure. I'm definitely contacting the bone, but it's not enough pressure to move the bone underneath. Pressure is a little bit down, but really mostly tractioning superior. Doing some cross fiber massage on the transverse fibers of the sacral fascia and bringing that stroke up over the sacral base into the divot where L5 and L4 live. And with each couple of strokes, we're just coming a little farther laterally, up and over the iliac crest. So if you find something that's stuck, you find something that needs movement, spend a little more time there. But what we don't want to do today is, if we find a nodule, just press on it. This isn't really about deep pressure. This is more about mobilization and circulation. So now just continuing up along the lumbar paraspinals, thinking about these thumb strokes almost like when you're vacuuming the carpet. You want there to be a little bit of overlap from stroke to stroke. And we're going from medial to lateral, and then lateral to medial, and then medial to lateral again. And I'm not quite coming out as far as the QL just yet. Let's bring these strokes up into the lower thoracic spine. If your thumb gets tired, you're probably pressing too hard, and you can always switch hands, give your hands a rest. The force here isn't really coming from a sweep of the thumb. It's really coming from my chest, my pecs and my triceps, and a little bit of a lean of my upper body so that I don't tire my hands out. There are days that I'm definitely less able to be connected to my center, and I have a harder time generating the pressure from my center. And those are the days that my hands are tired by the end of the day. Yeah. Our patient today is also a massage therapist, quite good. So she just made a little affirmative sound, like she can definitely relate to that. And Sitka's work is awesome. It's like a combination of Thai and Lomi Lomi, and really quite amazing. So I'm going to come back to the top of the table here. Give myself a little bit more oil. Let's come down and feel definitely a little bit more mobile, especially in the sacrum. Feels like the farther, more laterally I come here, the more resistance there is to this downward movement. And so that makes me think QL. And let's switch over to the right side again. And I'm going to demonstrate working the right side, standing on the left side of the table so you can see. So you can do this from either side. So here I'm just starting with a medial to lateral stroke. It's the fingertips, not a lot of pressure. Starting right at the midline, stroking laterally, getting a little bit of length and mobility in the sacral fascia. Here's a little more resistance, like a little nodular induration is one word, a little hardening. And again, the instinct might be you find something hard and firm and press on it. And if it doesn't let go, press harder. But we're not gonna do that today. In fact, what this feels like this needs is a little bit of a lift. Now, how do I know that? I don't exactly know. It's just sort of like a sense. So I've switched my position. I've changed to thumb. And this is the piece of tissue that I'm thinking about right here. And it is kind of a medium depth, and it's not in the glute max because the glute max is going to be attaching here. It's more the fascia. It's continuous with the gluteal fascia, the sacral fascia. But I'm trying to sort of think about getting my thumbs under it and mobilizing it superiorly. Good. It just let go a little bit, and I like that. So let's reach over, pick up her foot, and feel for this rotation. Now, what I can feel here is that her SI joint opens and closes really nicely, but there is a little bit of resistance to this rotation, but it's coming more from the upper thigh. So for the purposes of our demonstration today, we're not going to address that. But just kind of getting a sense of where all that is coming from. And now this inferior to superior, gentle, and you can see the rhythm and the speed that I'm using. Some people like to go really fast. I think it's more relaxing for the patient if you go slow, so the tissues aren't guarded. Having a little bit of a rhythm to the movement also kind of helps the patient's brain relax because it makes things more predictable. So here I'm using fingertip with a reinforce on the other hand, really leaning, not super hard, but all the force is coming from me leaning on it and coming up. You might notice here I'm taking a little more of a medial to lateral push on this section of muscle right here. Not forcing anything, just encouraging. And we'll come back up to the top here. Just finish this section with some gentle inferior to superior strokes, mostly palm and heel of the hand, a little bit of fingertip. And then one side and the other. That's a basic lumbar spine and sacrum neuromuscular therapy approach. From here, there's a lot of different directions you could go. I could look at that right upper thigh. We could look more deeply at this left QL, which would be more of a sidelining approach. A lot of different things we could do.